Hello, my name is Christine Franzese. I am a professor at the Department of Otolaryngology and Head and Neck Surgery at the University of Missouri in Columbia, and today we're going to discuss a brief update on chronic cough. Here are my disclosures. Some of them are relevant to this discussion, as I have been involved in some of the Phase 2 and Phase 3 trials for chronic cough. We're going to briefly review the current state of chronic cough management, including currently utilized medications, procedures that are non-pharmaceutical, such as superior laryngeal nerve injection, and some future medical developments, as well as discuss the different phenotypes of chronic cough and a little bit about their diagnosis. So let's dive into this. When we think about chronic cough, this is generally a vagal reflex that is evoked by the stimulation of afferents from the vagus nerve, with their receptive fields primarily being in the larynx and the conducting airways. These receptors may also be present in the alveolar septi, the parenchyma of the lung, pharynx, esophagus, and even the ear, which, as otolaryngologist, Arnold's reflex is near and dear to our heart, particularly if you do any kind of cerumen removal. You're very familiar with the fact that mechanical stimulation of the external auditory canal may trigger the auricular branch of the vagus nerve and incite a cough reflex. When we think about chronic cough, there are these noxious stimuli that are detected through these receptors and various ion channels listed there that are localized to the afferent vagal nerve with terminations in the airway mucosa. So what happens is these afferent nerves that are regulating the cough respond to a variety of different chemical and mechanical stimuli, Arnold's reflex being an example of the mechanical stimuli. Cellular stress causes the release of ATP, which appears to be important in the stimulus. Afferent neuronal traffic is then relayed by two different biochemical pathways, which I'll show you a picture of. And the cortical influences do modulate this reflex, with females seeming to have a greater area of their brain devoted towards cough. So you will notice that chronic cough does tend to have a higher prevalence in females. So let's take a little bit closer look at what we're talking about with these different pathways. So we have the exogenous pathway, which is irritants, particulate matter, and potentially acidic and non-acidic compounds from stomach acid and stomach contents, other things like that, which will trigger which are noxious stimuli, which will trigger an afferent response leading to a chronic cough. And then we have an endogenous or ATP-dependent pathway. Regardless where these stimulations are coming from, whether it's the larynx, the lungs, or elsewhere, this will then have a signal travel up the brain through the somatosensory cortex, resulting in possible hyperstimulation and the induction of chronic cough. So chronic cough is a very common and actually disabling complaint. It does affect about 5 to 10% of the adult population. Now, adults presenting with chronic cough as the primary complaint tend to have a common clinical presentation. This will include sensitivity to inhalation of environmental irritants, so they may complain about going into a store, particularly a grocery store, walking through laundry aisles, which may have a lot of fragrance or bleaches. They may complain about going outside into the cold air, as this results in a tickling sensation or an irritation that they will feel in the back of their throat. This tickle or irritation then drives the sensation that they need to cough. 2/3 of the patients with chronic cough are female, and the peak prevalence occurs in the mid-50s and 60s. Because of this neuronal activation, this suggests a heightened sensitivity of neuronal pathways mediating the cough, and this is what has led to the concept of cough hypersensitivity as a diagnosis. So what's the definition of chronic cough? Well, it varies depending on your age. So most guidelines have adopted 8 weeks in adults and 4 weeks in children. However, if you were involved in any of the chronic cough studies that have been going on for the past year or so, the inclusion criteria was different and required a chronic cough to be present for more than a year. Some cough in patients will occur on a daily basis over many years. Other types of chronic cough have a more variable presentation, where they may have a relapsing or remitting course. And the diagnosis of chronic cough has to include a kind of a global assessment to take into account the other features and the various phenotypes that might be present in this cough. So when we look at the epidemiology of chronic cough, there's no precise data, probably because this wasn't perceived as a very distinct clinical entity until recently. Instead, it was viewed as a symptom of other respiratory conditions. There's no agreed on definition of chronic cough for epidemiological studies either. That's another challenge. The most common reasons patients may seek medical attention includes concerns for other underlying serious illnesses. Patients may be concerned about malignancy. Extreme coughing may induce vomiting. Chronic cough also can disrupt the sleep cycle, so patients may complain of exhaustion, sleep disruption, and definitely social embarrassment, particularly in this pandemic era. A number of patients have been very afraid to go outside, not just because they don't want to get a respiratory illness, but it's because with their cough, people may think that they have COVID. So they may avoid going out even more than they did in the past. They may have difficulty speaking on the telephone, at work, or with clients. They may suffer from urinary incontinence, and they may annoy family, friends, and coworkers. The most impactful on health quality of life surveys are the stress, urinary incontinence symptoms, interference with speech, as well as depression and potential syncope. And individuals report on average 8 adverse symptoms associated with their chronic cough. So when we're looking at diagnosing with a patient with chronic cough, this can be difficult because there's a lot of diseases that may contribute to this. As you'll notice with the associated symptoms, they may have different throat symptoms, chest symptoms, and particularly symptoms of acid reflux. They may have asthma or other comorbid diseases, and certainly being a smoker, having sleep apnea, or being on an ACE inhibitor are all risk factors for chronic cough. So when you undertake a history and physical exam for a patient presenting with chronic cough, you want to determine how long the cough has been ongoing, how the cough has impacted the patient, and if they've noticed any triggers, if there's a family history of chronic cough or other associated disorders, using a visual analog scale or verbal range of 1 out of 10, a chronic cough score, and any quality of life indicators that you have available. And you may consider as part of your evaluation a chest x-ray, pulmonary function test, possibly a fraction of exhaled nitric oxide, and then a CBC or a complete blood count for an eosinophil level. So when we go into the different mechanisms, the mechanisms of cough hypersensitivity still remain a bit controversial. We understand that there's some T2 or type 2 airway inflammation that occurs in about a quarter of patients, and this may be through stimulation of the innate immune system rather than atopy. This results in the phenotypes of cough variant asthma and eosinophilic bronchitis. Reflux, particularly non-acid gaseous airway reflux and esophageal dysmotility, are common features in patients that have chronic cough. And so this suggests there's an underlying neuropathic process that's responsible for cough hypersensitivity. This is supported by the development of cough or chronic cough in certain forms of hereditary somatosensory neuropathy. So starting to dig into a little bit of the different phenotypes of chronic cough, the first phenotype we have is the asthmatic cough or eosinophilic bronchitis cough. There is no agreed single diagnostic test when you're evaluating someone with chronic cough to diagnose or exclude asthma. Spirometry is certainly necessary in the evaluation, so getting a set of pulmonary function tests would be extremely helpful. Within this particular phenotype, there are 3 subgroups identified: the classic asthma phenotype, the cough variant asthma, and eosinophilic bronchitis without bronchoconstriction or hyperresponsiveness. Eosinophilic inflammation may be a useful biomarker of asthmatic cough. Sputum eosinophilia is certainly the gold standard and the most accurate indicator, but it is time-consuming, may be difficult to acquire, and requires expert interpretation. Pheno, a fraction of exhaled nitrous oxide, may be a useful surrogate marker of eosinophilic airway inflammation. There was a meta-analysis of observational studies that showed that pheno had a relatively high specificity of 0.85 in predicting asthma among adults that had chronic cough. However, there's no consensus as to what is the cutoff level for an asthma diagnosis when using pheno. Blood eosinophilia may be characterized by diurnal and seasonal variability, so that usually will require some multiple assessments and interpretation with caution. An eosinophil count greater than 0.3 cells per microliter may indicate eosinophilic airway inflammation. So now we get to our second phenotype of chronic cough. This is the reflux cough. The prevalence of reflux and chronic cough has been estimated to be huge, anywhere from 0 to 100%. This is probably the largest range I've ever seen. It's thought that actually non-acid reflux, both liquid and gaseous forms, may be an important factor, but there's no method that reliably detects non-acid reflux. So this diagnosis relies a lot on clinical history and can be supported by validated questionnaires such as the Hull Airway Reflux Questionnaire or the Reflux Symptom Index. There is a high prevalence of esophageal dysmotility in chronic cough, and it may be that laryngopharyngeal reflux, rather than gastroesophageal reflux, may be more of the problem. Moving on to our third phenotype of chronic cough, we have the postnasal drip syndrome or upper airways cough syndrome. This is a controversial phenotype. Upper airway cough syndrome describes a variety of signs and symptoms that were previously referred to by other synonyms, including postnasal drip syndrome, rhinitis, and rhinosinusitis. First-generation antihistamines and decongestants can be recommended as a potential treatment in the absence of adequate randomized controlled trials. First-generation antihistamines are thought to be antitussive and centrally penetrant anticholinergics. Our next phenotype is iatrogenic cough. This is a chronic cough that occurs in about 15% of patients taking ACE inhibitors. So ACE inhibitors tend to increase the sensitivity of the cough reflex in most subjects. No patient with a cough who develops one should be given an ACE inhibitor. Angiotensin II antagonists do not affect the cough reflex. There are also other drugs such as bisphosphonates or calcium channel antagonists, which may worsen pre-existing GERD and increase cough. So you do want to evaluate the patient's medications in someone presenting with symptoms of chronic cough. Another phenotype of a chronic cough is chronic refractory cough. So chronic refractory cough is pretty much what it says. It's cough that has been refractory to conventional treatments of cough-associated traits. So despite adequate treatment, this cough has persisted despite adequate treatment and investigation. This is also known as idiopathic chronic cough or unexplained chronic cough. There are current and ongoing successful trials of drugs with neuromodulatory effects, such as opiates, gabapentin, and the new P2X3 antagonists, which suggest an underlying aberrant neurophysiology. And then there are other types of coughs to round out the miscellaneous cough phenotypes. There are coughs that are directly related to other types of diseases like cystic fibrosis, interstitial lung disease, bronchiectasis, and more. And then cough related to tobacco or nicotine use. So, when you approach the initial management to a patient with chronic cough, first, if you can identify risk factors such as smoking, tobacco use, medications, you want to try to stop those risk factors or alleviate them in whatever way you can. You may consider initiating corticosteroids, either oral or inhaled, or a leukotriene receptor antagonist, particularly if there are indicators that there may be elevated eosinophilic inflammation or a type 2 inflammation. You can initiate a proton pump inhibitor only when there are peptic symptoms or evidence of acid reflux is present. And then you want to follow up for assessment for your patient in about 3 months. If there's improvement, you'll continue and attempt to withdraw whatever therapy. If there's no improvement, there's a number of other medications that you can consider, and we'll also talk about some non-pharmaceutical remedies as well. Things that you can consider if there's been no improvement: low-dose opiates, promotility agents, gabapentin, pregabalin. There's also cough control therapies. Those are the non-pharmacologic control therapies. And we'll talk about some future developments. You may consider additional evaluation, including esophageal manometry, getting sputum for eosinophils, sputum for acid-fast bacteria. You may consider laryngoscopy, methacolon challenge if there's concern about the diagnosis of asthma. You may consider chest CT as well as bronchoscopy. So now we're going to get into the non-pharmaceutical remedies for chronic cough. So physiotherapy or speech therapy is a potential non-pharmaceutical method to control chronic cough. Vertigan et al. In his study demonstrated that a 2-month intervention by a speech and swallowing therapist significantly reduced subject cough score compared to placebo treatment. And in a multi-center study by Chamberlain Mitchell, weekly intervention by a speech therapist and physiotherapist for 4 weeks showed benefits over placebo for cough-specific quality of life and objective cough frequency, but not for the visual analog scale of severity or other quality of life outcomes. The improvements in the intervention group were sustained for up to 3 months, but not beyond 3 months, and there were no adverse effects found from the study. This shows potential promise. It may need several treatments or recurring treatments. This is a complex intervention. It does require some expertise in the speech therapists and physiotherapists that are doing it, and it definitely requires further study. We're also going to talk about superior laryngeal nerve block. So this has been looked at in several smaller studies and is something that is practiced by laryngologists. This involves injecting an anesthetic to numb or anesthetize the branch of the superior laryngeal nerve. This is an examination of how this particular nerve block would be done, and it's generally done in the office, although this particular nerve block can also be done by anesthesiologists. So in one study by Duffy, there were 13 patients over 2 years who had a neurogenic cough refractory to medical management or cough suppression therapy. These patients had some short-term follow-up and had a statistically significant decrease in their cough scores, with a mean baseline of a CSI of 24.3 decreasing to 16.15. Those patients with evidence of vocal fold motion or vibratory abnormalities actually showed more short-term improvement than those without vocal fold abnormalities. And then at long-term follow-up, those with vocal fold abnormalities had improvements that approached statistical significance, while those that did not show improvement. So again, that's where laryngoscopy may be very helpful. In another small study looking at a superior laryngeal nerve blockade, 18 patients with neurogenic cough underwent a percutaneous blockade of the internal branch of the superior laryngeal nerve in a clinical setting. And in general, these injections are done with a 1-to-1 mixture of a corticosteroid with a local anesthetic. Unilateral injections were performed in 13 patients. 10 were done on the left, 3 were done on the right, and 5 patients underwent bilateral injections. Patients underwent an average of 2.5 block procedures, with a mean follow-up time post-injection was 85.4 days. As you can see, there's a large range, though. The cough severity index scores decreased significantly from an average of 26.8 pretreatment to 14.6 post-treatment. And in potential upcoming therapies are P2X3X receptor antagonists. Now, currently there are no FDA-approved medications for chronic cough. There are some, as we've listed before, like opiates, gabapentin, pregabalin, that have been used off-label for this. Gefapixant is awaiting FDA decision. It has completed its phase 3 trials, COUGH 1 and COUGH 2. At its 45 milligram dose, there was an estimated relative risk reduction of 18.5% in 24-hour cough frequency in COUGH 1 that met its primary endpoint. In COUGH 2, the same dose, which is 45 milligrams, led to a 14.6 relative risk reduction in 24-hour cough frequency. The 15 milligram dose, however, failed in both trials. There are other potential P2X3 receptor antagonists coming out. There is elapixant, which met its primary endpoint in its phase 2b study. There is sivapixant, which is in an ongoing phase 2 study. And Blue 5937 has an ongoing phase 2b study as well. So in summary, chronic cough has several phenotypes, which we've reviewed. A thorough history is definitely necessary with appropriate investigative studies, pulmonary function tests, blood counts, chest x-rays, and appropriate medical management is definitely necessary. But despite your best efforts at investigation and treatment, the cough may still persist. Our understanding of cough hyperresponsiveness is improving, and there are some non-pharmaceutical options available, including superior laryngeal nerve injection and cough physiotherapy or speech and swallowing therapy for chronic cough. And we may have some new medications available soon. Thank you very much.